Hello, we are ready to start. So, welcome to our sixth webinar of the series MediPIET at Home. We hope it finds you and your loved ones all well and safe. My name is Adela Paez, and I'm one of the three MediPIET scientific coordinators with Iro, Eva Pleidu, and Angelique Lambrou, who will be moderating the questions and answer section. Today, we are very pleased to have with us Professor Dale Fisher, infectiologist at the National University Hospital of Singapore, and also Professor of Medicine at the John Lulin School of Medicine, the National University of Singapore. Professor Fisher is also the chair of the National Infection Prevention and Control Committee at the Ministry of Health of Singapore, and also chair of the steering committee of the Global Outbreak Alert and Response Network, GOARN, hosted by the World Health Organization. So during his talk, Professor Fisher will share his insights about the outbreak response adapted to asymmetric epidemiology of COVID-19. And after that, please, we encourage to send us your questions in the chat box, or also if you accept, since the webinar is going to be recorded, you can also raise your hand and we will invite you to ask him directly the question. So thank you very much for joining us, Professor Fisher. We are very honored. So over to you.
Thanks, Adina. I think, can I assume you can see the screen and the mouse and hear me well?
Yes, we do hear you very well. And
great.
See the screen.
Okay, great. Well, thanks for giving me the privilege of addressing your group. I'm going to, I know you're epidemiologists, so I'm going to talk a little bit about epidemiology, but I'm a bit frightened because I don't like talking to an audience about something they know more about than me, but I'll give it a go, and I'll talk about really some of our experiences in Singapore. So we're obviously all very familiar with this chart from Johns Hopkins University. We probably all look at it most days, and you can see we're up to almost 8 million people and approaching 500,000 deaths now. We know this is fairly increasingly meaningless, I guess, especially the number of cases, because so many times people are underestimating their cases, and the serology confirms that. But nonetheless, it's an indication of the testing that's happening. And you can see down here, we know about US, Brazil, Russia, India, UK. We know all that. We know the death rates, which are fairly accurate. Again, not completely accurate, but more reliable than the cases. And we can see those. But they're obviously very blunt because you can see all these dots. And in fact, if you zoom down on America, you'll see little dots all over the country, obviously, because it's not one outbreak, of course. It's many millions of, or hundreds of thousands of outbreaks going on in various different settings. And here you can look at each country, because it's Johns Hopkins is in the US, I guess, so most countries here only get one dot, which really just tells you that they're generalizing that that's what's happening in the country. And here's Singapore with a nice big red dot there. So again, it's the point I'm trying to make is that the epidemiology at a global level is very blunt, and this is obviously the epi curve with China out the front here, and these brown ones being the Western Pacific region of WHO, very small contribution to the overall total. The blue one's the Southeast Asian region. Then going above that, we've got Europe, which was obviously high back in March, April, but it's coming down and being a much lower contributor now. Here's where you are. I think most of the people in this audience are in the Eastern Mediterranean region, and there's the Americas. The cases are going up, you can see, and I think we'll all agree that's almost certainly testing, although many countries have come down. And the number of deaths is coming down, and again, that's probably because we're getting better at it. Probably what's missing here is the number of cases clearly should have been much higher around here. But the world is running at about 12,000 deaths a day now, and around 140,000 cases per day. But again, that's very blunt, right? So we break it down to the regions, and you can see what the epi curves look like in each region. So Afro, EMRO quite similar. Euro we know is coming down, and with the high death rate or / low case ascertainment rate. The Americas, CRO, Southeast Asia, and Western Pacific regions. So everyone's got their own epidemiology, and we go down a little bit lower, and this is within WIPRO. So you can see how China was the biggest contributor at the start. Then Korea had its cluster in Daegu. Now you can see that Singapore in the blue with its dormitory clusters has become a much stronger contributor to the number. So let's keep drilling down, and now we can look at Singapore. And we've really got three different outbreaks, if you like. These were the imported cases, and you can see now these are having a very negligible result on the overall numbers. There's very few people flying in, and of course they're in quarantine anyway, even when there is a case. This is the community cases. The most we ever got up to in a day was 70 cases a day. And this was the day we introduced what our Prime Minister called a circuit breaker, which is sort of a lockdown by anyone else's term, but it really wasn't the rigid restrictions, but many businesses were closed, schools were closed, masks became compulsory, people were urged to work from home. But this happened at around the same time that we had this outbreak, which is the dormitory outbreak. And you can see when people talk about, oh, how many cases in Singapore today, they might say, oh, 450. And the contribution from actually the community is single numbers. Well, you can see 2, 3 there in the last few days. Whereas over in the dormitories, it's 300, 400, 500. So they're all coming from foreign workers in dormitories. So you can see this requires completely different interventions. The circuit breaker that was introduced for the community cases has no bearing on the dormitory residents, and I'll explain why. So the dormitory, this is Singapore, if you've got an imagination, at this sort of flattened diamond shape. And it's divided into health clusters. So this cluster is called NUHS, National University Health Systems. This is National Healthcare Group, and this is called Sing Health. And each of those has got, if you like, a flagship hospital. So I work at NUH. So we were asked as a cluster to look after the dorms because it was such a huge scale. So these dormitories there's 43 purpose-built dormitories, and the largest has a capacity of 25,000 men. The smallest of these is about 5,000, or about, some are 1,000, but generally the smallest are 5,000. And there's plenty of 16, 18, 12,000. So these dorms across the country house about 300,000 people. Now, on top of that, there's what's called factory converted dorms. And these can have anything from 10 people to 400 or 500. I think the largest may be 800. and there's 1,200 of these. So you can see the foreign worker population is about 1 million men. It's about 20% of the population, and they're from Bangladesh, India. That'd be the two predominant ones. Also mainland China, and they do most of Singapore's manual work, to be honest. Now, the outbreak spread between the dorms because these men get together on their days off. So there's large retail outlets that where they congregate, and they know each other. So basically, every purpose-built dormitory of these huge 43 blocks all became infected, and each healthcare sector cluster was asked to look after theirs. So this is this corner of Singapore. So again, this is Malaysia over here. So this is all Singapore around here, lots of reclaimed land. And we were given 14 dormitories to look after. Now, this is a typical one. So this one is about 16,000 people. And you can see it's got medical clinics, a beer garden, games, mini mart, food court, movies. So these are small towns basically in themselves. And the first time I was asked to engage in the dormitory outbreak, I went and had a look at it. To be honest, I didn't even know these existed. I'd never really thought about it. I knew there were a lot of foreign workers, but I didn't understand their housing. And I went to this one, which is called S11 for some reason. And the first thing I realized was that these men had been asked to stay up in their rooms rather than mingle as the first step to try and control the outbreak. But these men were getting no information. This was where I first had a light bulb in saying, oh, look, this is a last mile problem. I'm sure you'll all be familiar with that. This was all their food arriving, but because the system wasn't in place normally to provide their food, they cooked for themselves or they bought for themselves. Now it was stay in your room, we'll bring you the food. But the food wasn't getting there. So they were coming down, and they were also coming down to find information, saying, what's happening? Why are we told to stay in our rooms? Why aren't we going to work? And by the way, I'm really hungry and I can see a whole lot of food sitting there. So this was the early days of the lockdown in this dormitory. I could see out the front there were boxes, and these were kettles and drinks and things like this. Also, all these things that weren't getting to the men, because basically I think these men were delivering and these were the ones distributing to 16,000 people. So a huge coordination problem. And I realized that we already had communications issues, we had logistical issues, and I thought, this is actually just like any other outbreak. And here is a picture from the end of an Ebola outbreak in Uganda almost 20 years ago. You can see all the usual players. So here's the contact tracers, and there's some doctors and some ops people. But what I want you to do is look at this this graphic here in the middle, and as you zoom in, this is what it shows. This was the Ebola control strategy for Uganda, and it was case management, laboratory, social mobilization, and surveillance and epidemiology. And I was so happy the first time someone gave me this slide, because it's so valid. So you can look, the case management had burial teams, ambulances, screening. I guess this is IPC, patient care, laboratory, music groups, all the things that were relevant to that context. And many of you that have been involved in GOARN will be familiar with this slide. And this is really part of our Bible, if you like. And it became case management and funerals, surveillance, epidemiology, laboratory, logistics and security, social mobilisation, health education, which we now call RCCE, and coordination. And I thought, well, let's apply this to what's needed in the dorms. So this is Sumaitenga dorm. This is the 25,000 one, right? Now, each of these blocks, you can see some men on the steps. We told them to stay in their rooms, but that's obviously not easy. There are people wondering what's happening, mingling on stairwells. But so this is a block of 2,500 people. This is a block of 2,500 people. This is a block of 2,500 people. So there's 10 floors. So there's 250 people per floor. And there's about 20 rooms with 12 men in each room. So this is the density. So you think each of these has got 12 men in it. 10 floors, and there are 10 of these buildings. So there's 1, 2, 3 of them you can see. There's another green one behind. Over to the left, there's 2 more, and then there's 2 behind me. And they all center around this courtyard. So as I tried to apply this, I thought, you know, we were originally asked to come in and just swab the men. So we had swabbing teams. That's why I put it in red. But then other people around me started to say, this is a lot more than swabbing. So I created this based on the GOARN one. And it was really to establish that all these dorms had been blocked off, and they're still blocked off today. So these don't mix with outside Singapore society. So I put all these things, the rosters, the patient flows, the IPC, how you design makeshift areas. What do you do if someone actually dies there? How's that going to be managed? Laboratory, a lot of these men, we didn't know who was in these buildings. They'd just been rented out by a company. And actually the dorm operator didn't even know the names of all the men. And in fact, when we did find out, a lot of men had the same name. So identifiers was a real problem when we were doing testing, because then when we might swab them and send them back to their room, but then we couldn't find them again. And at one stage we had about 50 men that were positive, but we couldn't find them again. They'd just gone back in and didn't come back. Obviously mild disease. Epidemiology, we did a lot. The first times we went there, people would say, oh, this is a goner. Everyone must have it. And I said, no, that's not how it works. Let's do some epi. Let's find out. We're going to find rooms infected, rooms not infected. And if we're telling men stay in their room because no one else in your room has had it, then this is very useful information. And when we did it, we actually found whole floors that weren't infected. So there was a lot of effort put into tracking individuals, tracking the rooms, huge data management, and we ended up getting volunteers to come and help us with all this data, and just in terms of maintaining a database of 20-odd thousand people and what their results were and what room they were in, policies on who to swab and things like that. The logistics, getting in all the medical supplies, masks for the men, alcohol-based hand rub, cleaning equipment, food management, obviously a huge logistic thing, establishing where the clean zones could be for staff, ambulances. We eventually got provided with an ambulance just because we had so many people that were infected. All these things needed in logistics, and as well as that, we had to take care of their regular health needs. But the one, like always, the one that got forgotten was community engagement and risk communications. Every outbreak I've been to, it always is last. And I started saying to people, I want a comms team. I want to be able to get messages to the men, and I want to hear from the men, because otherwise, you know, the best scenario is we can help them to help themselves to not get infected. The worst scenario is it tends to be a riot because people aren't getting information. So So we ended up with a comms team and did really well, I believe, to get this up and running. I'll show you some examples later. So here's the epidemiology. We did start assigning results to rooms and working out where people were. We could soon see that as the epicurves were forming. So here's one particular block by date, and we could compare which were the hot blocks and the cold blocks or whatever. Here's one of the levels, level 4, had actually had no cases. But look, we also found level 9 had only had 4 cases, and they were in 2 rooms. So that means there were like 18 rooms that hadn't had a case. So we were able to prove that actually, once you do the epidemiology and break it down, we could learn a lot. This was another block with a different epicurve. It's sort of fairly consistent, and more rooms and more cases were affected. But still, even in what could be regarded as a fairly dirty block, most of the rooms, remember there's 20 rooms on each level, most of the rooms hadn't had cases. So this was what we used in the early days to prove that we needed to do a conventional outbreak response. So here's the spot map of one of the blocks. So just watch it. Here's the date here, and it's not going to go by itself. Okay, so you can see just as the days go by, where cases appear and little hotspots in the blocks appear. So the first thing you're probably thinking is, why is it so slow? Because there's obviously transmission going on over that month or so that I've just demonstrated. But you can still see that there are quiet floors, but then there's little hotspots in some areas. So this brings me back to this, that it was so important that we develop epidemiology, and then also to do all the other things, which were obviously case management, and one of the strategies was to pull out everyone that was over 45 and put them in hotels in Singapore, because we thought that would be a good risk mitigator, as obviously age carries a higher risk. So let me just take you through some of the case management. So men, we really promoted that men with symptoms or fevers, everyone was checking their temperature 3 times a day. They would come down here, and there'd be a medical clinic established in every dormitory to provide care and to swab. And as time went by and the ARIs started coming down, we find that people are more there for other problems, a lot of dental problems, things like that. But we had to provide that care because the men weren't allowed to leave the campus, actually leave their room. And this is sort of this was a clean area at Sungai Tengah where we could go and actually have some downtime. And here's another one. This is Thomas. He was in charge of the dorm operation. Here's a little strategic meeting going on between the ops manager there and some of the other doctors, and just talking about some of their concerns. These are some people putting together care packs, because we had a lot of donors giving soap and masks and things like that, so that we could distribute those to, and chocolates and things, so that we could distribute those to the men that came down. This was one of the nice, in Singapore, we've always isolated all our positive cases. So this is Expo, huge facility out not far from the airport. So this was completely reconfigured so that men could come in, register, and spend their couple of weeks here until they were cleared and allowed to go back to the dorms. It's a big operation. This was the ops center, a laundry room, and relative comfort really for what these men are used to. This is one of the engagements that we were doing. So we would get the level leads down. So we established that there was a hierarchy for communication within. So every room had a lead and every level had a lead. So that means 10 per building. So there's 100 level leads. And we made some written materials, which are now also available electronically. And we would get these men down maybe every week and have a conversation with them face to face, ask them how things are going, and also give messages on how to protect themselves. This was done by a junior doctor who is a public health physician, and she really warmed to this. So she made these up, and one was for dormitories. This one I think is for the isolation facility, and this one was another facility. We had a swab isolation facility, so sometimes we'd swab people and keep them isolated just for the 24 or 48 hours until we got the result. If they had symptoms, if they were negative, they might stay there until their symptoms went away on the basis that it was something else. But if they're positive, then they go into the community care facility. So you could see a different message for every area, done by a face-to-face engagement, now available online, and it's also in 8 languages, so to cover every type of dormitory worker. And this was calls for volunteers. So lots of our hospital staff were there doing swabs and medical care, and especially from areas like surgery where there's not a lot of surgery getting done at the moment. So a lot of theatre nurses, people like that. This was a Bangladeshi neonatologist from National University Hospital. So so he's done a lot of work as well. So people that speak Tamil and Bangladeshi were heavily utilised by us in our engagements. So I just want to car park all the dorm stuff to say, I'm sure you can see now how each of these major pillars of an outbreak response are applied to the dormitories, and still are. It's none of them are open yet, but we can expect to see some start opening over the next few weeks. What I want to do is just show that that this can be applied also to nursing homes. We've had 6 nursing home outbreaks, and the first one was in this fairly old nursing home. It had a 111 bed capacity. It had 48 males and 55 females at the time, with 61 staff. It was done in 3 blocks. This was a male block. This was the male block. This is a female block, and this was half males and then half females. So I thought, okay, we went through that, and then what we found was that the work we did in getting over that outbreak was actually applicable to any, and this is Orange Valley, the home of the most recent outbreak. So I put the pillars up there again, and really what we've done is the same but adapted. So the first thing we went was going in there, and we would look at all the workflows, the staff, and we found that they had a Team A, Team B concept with their staff, that only lady staff, only female residents were looked after by Team A, and the male residents were looked after by Team B. So this actually made things a little bit different because we'd had some sort of segregation. So I just want to perhaps not go through this in too much detail, but we had to really understand what was happening with the staff, establish clean and dirty areas for all the IPC, get some swabbing teams in there to work once we realised who would be contacts, we would swab sort of aggressively, and how we would monitor the contacts. And this other concept of even if you're leaving people there because they're it's hard to move a whole nursing home. The people that were bedbound, it was easy. People that were mobile but had a good mental state were easy. But there were a lot of, or not a lot, but a number of demented people who would wander around and sit on different people's beds and things like that. So that was definitely a challenge. How we'd engage with the labs and get all the results back. Epidemiology, just establishing what visitors had been there, what staff had been there, what are the staff sleeping arrangements, and we found actually there was a fair bit of mingling between the two teams of staff. Activity mapping, the logistics, we had to work out ambulance routes, which hospital they would go to, which type of ambulance you'd call, staff that were put on quarantine, which was all of them in the end, and where we would keep those. There's a whole new world of waste management once you scale up the IPC, and medical supplies in terms of PPE, extra cleaning equipment, extra cleaners, pulse oximetry, things like that. And again, not to forget RCCE, which again was the last thing to be remembered when someone said, what are we going to tell the families? So you have to work out how to do that in a sensitive way that they may have been exposed to COVID because there's been a case. So this was day one of this response. And it's important to note that she was from the Agency for Aged and Integrated Care. He was MOH. I was there representing infection control in MOH, and she's MOH. This was a swabbing team from a nearby hospital, Tantop Singh Hospital, also AIC. These were from the nursing home itself. So you could see the first thing the coordination needed was this cross-sectoral coordination, if you like, because each of these people, whether you're from AIC or the hospital or MOH, you've all got something to offer through those four pillars. So we actually ended up swabbing everyone first time round. We tried to rationalize it a little bit, but we couldn't. So this was the index case. The dark yellow represents the ones that we swabbed the next day. So, and look what happened. There was 1, 2, 3, 4, 5, 6, 7, 8 females and 1 male. So somehow it still spilled over into the males, but there were 8, and it was so limited to females, except for that one exception, which really spoke highly of the Team A, Team B concept. And we kept swabbing every 7 days. So 7 days later, we did everybody again, and we got less. We got just this one, this one, this one. And then 2 weeks later, this one came up. But what we did each time was, if you were positive, you were moved to hospital. That gave us a better chance to space it out. And also towards after the second round, the dark yellow round, we actually moved out these people and this person and the wanderers. So altogether, I think it was about 12 people that we moved to a nursing home, which actually wasn't open yet, but it was ready to go. It had just been commissioned, but it hadn't been filled up. So we thought, can we use this just to break the back of this outbreak? So we did. We took out the wanderers. We took out the really high risk contacts, so they could be in single rooms in another empty building, and the outbreak was over. So I think of what makes long-term care facilities different. They have atypical presentations. Many are non-communicative. Many aspirate anyway. They aspirate on their food, or they've got chronic coughs, or they don't mount a fever. And they certainly don't sit up and say, I don't feel well, many. So the presentation is difficult, and this is why we were so proactive on the swabbing. Mobility makes it interesting. Some are bed-bound, but then there's these wanderer concept. Isolating contacts is challenging because there's no isolation facility here. We couldn't take every contact away and put them in a hospital. So it was where could we put them? So again, we had to be a little bit innovative. 4 of these people died, so the case fatality rate was 28%. And the other thing is all support needs to be provided, at least in Singapore. These are very under-resourced establishments. They can't produce swabbing teams. They can't produce all the PPE. They can't produce the ambulances or the logistics. We actually quarantined all the staff. We found 2 staff positive in the female side. And because the staff mingle so much, we quarantined all the staff and had to bring in another team of staff from other nursing homes. So again, all the support from multi-sectors needs to come in. So, and then after the 6th nursing home was found contaminated, we're pretty sure the healthcare workers are coming in with very minor symptoms. This was the team going out for a major logistic exercise to swab every staff and every resident of nursing homes in Singapore, about 30,000 people. A major exercise. They found 1 healthcare worker and 4 residents of the same place. This was one of the techniques to save on lab testing. Because we knew it was a low risk, we pulled 5 swabs per transport medium. So we found this is just as sensitive, and it does save on a lot of reagents. So if I just flick back to this, the whole point is we were able to control the nursing home cluster with communications, case management and IPC, laboratory, epidemiology, and logistics, and coordinating it with a multi-sectoral team. So my take-home messages are that you can't look at a country and talk about its rate. Obviously many countries have uncontrolled community spread, so that's a bit untidy. But once that goes away and you've got control, you start to see clusters. I'm sure I'm preaching to the converted here. And it becomes very asymmetric. You get whole areas clean, but then you'll get a nursing home here, or a school there, or a factory there, or in our case, dorms. But the major pillars of the outbreak response are invariably needed. And you almost have to think about them sometimes to say, what aren't we doing? And you go, and I can tell you in the dorms, it was, we forgot to do epidemiology. We forgot to do risk communications. And they certainly have made a huge difference. And many men haven't gotten infected because of the way we can manage this. But each pillar is more or less important in different contexts. But I am sure that you can't say that any one of them isn't needed. And you just have to think about it for any given context. So that's all I wanted to say with regards to the talk. I thought since I've got you here, I might just give a little plug for, I don't know if you know about these yet, but this is an incredible series that we're running every Thursday, where I start off with some epi updates, and then we get great speakers, and this one happens to be when we had Bruce Aylward on, they're very interactive. They're looked at by about 5,000 people every week from about 73 countries, I think was the last count. So some of them are just more chatty, some of them are didactic lectures, but it moves around a fair bit. As I say, I do 10 minutes on epi updates, then there'll be a main speaker for about 40 minutes, and then I'll come back for about 10 minutes on just some topical points from the week. These are some of the people, and these are the talks coming up. So on Thursday this week is Marie-Paul Kenny from INSERM. She'll be talking about vaccines, but you can see we've got Peter Piot, David Patterson, Richard Horton from Lancet, Chikwe from Nigeria, Jeremy Farah. So some pretty household names there. So with that, I hope you're still there, because I haven't heard anyone else. And I'll pass back to you, Adina.
Thank you very much, Professor. And we actually have shared the information about your weekly webinars, and we encourage all of you to join them. So thanks again for sharing your wisdom so clearly. So it has generated a number of questions in the chat. So I will give the floor to my colleague, Angeliki Lambrou, to moderate this part.
Hello, Doctor. Hello, Professor Kaiser. Thank you in advance. Thank you for your very nice presentation, very informative. So I will address to you a couple of questions that have been written in the chat, and then if I may, I will also take the opportunity to ask you a question. So we have two questions from our other colleague, Evla Bidus. So she also thanks you for the presentation. And a question is that, in case, I don't remember either if you have mentioned it, but how many additional resources in terms of human resources and logistic did you need in order to start and maintain such a response? And as a follow-up to this, how long did it take you to organize it? And I follow up this, and what are the biggest lessons learned in terms of this aspect?
Okay. They're all good questions. I'm not sure we know how many people are involved. The hospital work was really pulled back. Nothing. Okay. So we're up to about 40,000 cases now. We started off this with a policy of anyone that's positive gets admitted to hospital until they've had 2 negative swabs. And that was fine for a while, because the hospitals had been, I guess, retasked. There was very little elective work going on. We maintained sort of cancer work and heart work and stroke work, but most other things were pulled back, and a lot of the wards became COVID positive wards, isolation wards pending a swab. So most people were retasked, I guess. We got blown away though, and once it became clear that the hospitals were going to be overwhelmed with a policy of isolating everyone that's positive, we developed these community isolation facilities. So you saw one in Expo, but Sungai Tengah we decked out under the car park. They've got an undercover car park, so we decked that out. There's old abandoned buildings were quickly done up. Part of the problem with doing up these old buildings was that all the workers were in isolation, so there was no one to do the work. But we ended up creating 20,000 isolation facilities, and that allowed us to decamp the hospitals a lot. So we stuck by our belief that positive cases should be kept in isolation or cohorted. I would just say thousands. There's a lot of volunteers There's a lot of staff have been hospital staff, GPs. Yeah, I think it's just thousands, because it's taken 43 dorms. I can tell you at the biggest one, there's at any one time there'd be 50 there, but people are still doing their hospital work. So but we've got some university students have volunteered to come in and do data management, for instance. Singapore Airlines cabin staff have backfilled a little bit in the hospitals, so they might be doing some of the assisting nurses. So you need less nurses in the hospital. So you could be in hospital with your whatever disease that's not infectious, and you might get your meal served by a hostess from Singapore Airlines. So a lot of volunteers. I don't know the number, but it's certainly thousands. What lessons learned? Our biggest lesson was letting this happen, and even when it happened, we were slow. I guess it was March when the first cases happened, and we didn't really get into action until about April 7, 8. And then it was just so complex, because the people involved, there's the dorm operators, there's the Ministry of Manpower, Ministry of Health, the police force got involved, the armed forces got involved to help with logistics and other things. So it hasn't gone quickly, and in retrospect, you've got to look for the hotspots, or the potential hotspots. And I'm actually in a group now where we're sort of trying to scan Singapore to see where's the next blind spot. But this was a very vulnerable area, and I think we were slow to realise that. In fairness, at the time, we didn't know so much about pre-symptomatic or asymptomatic transmission, and we thought that if people had symptoms, then we could stay on top of it. But that's the biggest lesson there now, is prevent, or act quickly once you see a hotspot getting involved. So I don't think that would happen again, because people aren't gathering in big groups. And one of our biggest clusters before this was a singing group with hundreds of people doing karaoke in a room. That caused a lot of people, and you just wouldn't do that now because we know more.
Thank you. That's yeah. I am pretty sure it's a big task, and having those volunteers, it's extremely nice. I think it was an opportunity for all of us to regain our volunteer spirit. Another follow-up question from my colleague is how do you convince the hesitant decision makers, from ministers to directors of public health institutes and specific departments, to allocate more resources or to reshuffle the resources in order to respond to the country outbreak? And we are asking this especially if the country are low or middle income.
I think, yeah, so Singapore is quite wealthy, and they actually had a stockpile of money for an event like this. So I didn't know that, but I thought that's pretty smart. We don't even have to print money. We just have to open the safe. I think you need to make it clear to governments that you'll save a lot more money preventing disease than you will ignoring it. And then you get this terrible situation of tens of thousands of people in your country dying, and you still end up going into lockdown. So there's plenty of studies that show now that you act early, you reap the rewards. And I think Australia and New Zealand are examples of that. They're now opening with very low numbers, whereas other countries are opening because of the economic demands, but actually they're not ready to open because they've still got so many cases. And it's I fear what's going to happen. So early activity and rapid response and prevention.
Yeah, no, I'm coming from a country that I'm coming from Greece. Always, a lot of the budget allocated to health was, the great majority of it was allocated to secondary healthcare. So I think this epidemic proved otherwise, that the prevention is what is that I can give you more benefit in the long run. So I totally agree with you. A question from Adela, actually. Adela, do you want to address it, or should I address my question?
No, go ahead, please.
Okay, so I had questions because it was an interesting work that I think Adela is also congratulate you on controlling the clusters at the dormitories. But I had a question in terms of the nursing homes. So you mentioned that you were contact tracing, including the visitors. So I would like to ask you, so during the lockdown, I'm guessing the visitors were not allowed, I'm guessing, but when was the point that this measure was lifted up, if it existed? And yeah, because I know it's not beneficial for especially the demented patients and the old people not to see their families for so long. But for some, and I would say several countries, the visitors are not still allowed in the nursing homes.
Yeah, so I think different countries have different levels of nursing homes. The Singapore nursing homes, the people, the residents there, I must say, are further, I guess, more physically and mentally disabled than many other countries. So I think in Singapore, people tend to look after their elderly for a bit longer. I certainly know in other countries, particularly developed countries, they might even want to go in there so they can meet and mix people. So and they're very mobile and still mentally switched on. So in Singapore, I'm sad to say that most residents don't get visitors very much. In this particular example, there was a grandson came to visit, but because the index case was asleep, he just left. So we didn't call him a contact. At that stage of the outbreak, this is late March, there was they were allowed one visitor. Now visitors are banned in Singapore to nursing homes. And I haven't heard that that's a big problem. So as I say, sadly they don't get many visitors anyway.
Yeah, well, that's a good point, because I guess yes, it is different in between the countries for sure. So a follow-up question. So Adela, because we are in the nursing home situation, Adela wanted to ask, so what would be your advice on how to stop transmission at big elderly homes, the ones that have over 500 residents?
Yeah, well, if you can't isolate contacts, which is obviously the most desirable thing to do, and you do have big nursing homes with many people sharing a room. Firstly, you've got to minimise contact. So as far as the residents go, if they're bedbound, it's easy. If they're intellectually okay, then they need to have a good understanding of their responsibility. And as I say, if they're the demented wanderers, then they're challenging, and maybe they get moved out somewhere else. I think testing frequently is important. During this, people were saying, "Oh, let's just test 2 weeks later," and I said, "No, it'll just take a lot longer to get rid of it. And if we can test every sort of 5 days or whatever," it turned out 7 days was easier because then you could just do it every Monday. But I think testing, pulling out the positives, and just keep next week, test, pull out some more positives. Eventually you'll get there. As I say, the best thing you can do is isolate everyone as individuals, but yeah, that's not feasible in many countries. As well as that, we up the infection control. So lots more hand rub available, and staff were wearing sort of a lot more PPE in any of the resident areas, bearing in mind that these could be contacts, and they might be sort of asymptomatically positive, even if the swab was negative 3 days ago, sort of thing. So in any of the resident areas, they would wear gown, surgical mask, face shield for suctioning, and gloves.
Thank you, Professor. We have an additional question from our colleague from Serbia, Danelia Simic. So she is asking whether you had production of PCR tests in the country, and whether you used serological tests as screening tests for some categories of the citizens.
Is this about nursing homes?
I think she's asking in general.
Okay. No, we import our reagents. There was a concern in March, I think, with the availability. So that's why people did ask, you know, are you sure we need to swab the men as well as the women? Are you sure we need to do it every 7 days? So there was some penny pinching, and we sort of had to express, look, if we can't control this quickly, these people die. So this is a case where you do extra tests. We have ramped up a bit. So Singapore at that time was 5,000 tests a day, so not many. We can do, I think, about 20,000 a day now. We're targeting 40,000 a day. Our research labs haven't really provided what we had hoped, and sort of they wanted to get on with their research rather than being branded as COVID testers. So nonetheless, we've ramped up a fair bit. That's on testing. Serology, we're doing serology in the dorms. We've really had so little spread outside of the dorms. There's only a total of around 500 cases in the whole country. So there hasn't been a big push for community serology. We've done some serology on healthcare workers just as part of a research project, and well, we haven't found any yet. Still doing it. But in the dorms, some of the most affected dorms, yeah, they're up at 80% positive. So I guess that's approaching herd immunity. I don't believe that herd immunity is 60% in the dorms. It's so dense. So I still think they could get up to 80 or 90%. So serology is a strategy for the most affected dorms to try and clear them and work out who's got it. In the less affected dorms, we're still swabbing, which is why we're getting into trouble for keeping the numbers high.
Okay, yeah, that makes sense. So I don't see any other questions on the chat, and we just have 2 minutes. So I might take a little. Do you have a couple of minutes for a last question?
Okay.
Yeah, I have just the last question, because you're talking about dorms, nursing homes. So I wanted to ask you, because in some of our countries, there are clusters happening in people that are very mobile, and they tend to live in open spaces, like Roma people. So I don't know if you had that experience in Singapore, and how you dealt with that. Because in this case, not all the hesitant people are the people themselves in terms of, isolation and other measures.
Right. So they're more like gypsies, you're saying, are they?
Yes, exactly.
Right. No, we don't have gypsies in Singapore, but I'd love to see how an outbreak amongst that group would work. I would just make the point that those pillars that I've been talking about, that's what I would apply. But it'll be different. But you still need the risk communications, community engagement, case management, the epidemiology, and the logistics. And some will be more important than others, but it's it'd be great understanding all their movements and what are the sort of transmission sort of hotspots for how do they do it? Do they have mass gatherings, or is it more family cluster type spread? Or it'd be fascinating to design the interventions in a group like that.
Okay, thank you. Adela, back to you. I don't see any other questions on the chat. Thank you very much for your input and insights, Professor Friese.
My pleasure.
So thank you, Angeliki, and we just wanted to really say thank you to Professor Fisher for sharing your experience with us. We are extremely honored. And we also wanted to acknowledge all the participants from Mediterranean, Black Sea, and also EU countries. And especially we know that some of you are currently facing the peak of the pandemic. So Professor Fisher, rest assured that we are going to put to good use your guidance. So thank you very much to all of you, and then we hope to see you in a couple of weeks in our next webinar, or this Thursday in the one from the Singapore University with Professor Del Fisher. Thank you very much.
Okay, my pleasure. Thanks.
Bye.
Bye.